the ugly relative at the wedding. No one wants him there.
Hello, I'm Tim Russert, and welcome to the Fred Friendly Seminars. In hospitals, doctors' offices, and medical schools, there is one word that is rarely, if ever, heard: the word death. Most Americans, even doctors, don't like to hear or think about it, as if not breathing the monster's name will prevent its next visit. But avoidance has its cost, and today what we fear most is not so much death itself as the modern medical nightmare. A death alone, in pain, tethered to expensive machines that merely prolong dying. Our experiences with the death of loved ones has made us all wonder, isn't there a better way to die? Is dying in America more impersonal, painful, and expensive than it needs to be? Should physician-assisted suicide be an option? Has medical technology made us think of dying as a failure rather than a natural part of life? Now let us join our distinguished panelists as they wrestle with these profoundly personal questions that all of us must face before we die. Before I Die, Medical Care and Personal Choices. Our moderator is Harvard Law professor Arthur Miller.
Panelists, I want to welcome you to Centerville. Centerville is a medium-sized community somewhere in the center of the United States. And a good deal of the life of Centerville is centered around a bookstore called the Browser's Bookstore. And in the course of our conversation, we're going to meet a number of people who hang out at Browser's Bookstore. The first person we're going to meet doesn't happen to be in the bookstore today. It's Kathleen Johnson. Kathleen Johnson is married, 2 lovely young children. But today, she's in the hospital. As a matter of fact, Dr. Newland, she's with you. What's happened is that Kathleen has a primary care physician, and some time ago, the physician ordered a biopsy. And the biopsy revealed that there was some cancer. And that required surgery. And you've now looked at all the pathology reports. And they are not too positive. Indeed, they show locally advanced breast cancer, cancer in the axillary lymph nodes. And Anna, you're Kathleen. You knew there was some cancer, but you certainly didn't know it was this serious. Dr. Newland, talk to Kathleen.
Kathleen, we've got to talk about the results of your biopsy. It hasn't turned out the way I had hoped it would turn out. There is serious disease in it. It is malignant. In other words, it is cancerous. There are many things that we can do for this particular kind of cancer and for the stage at which it's at. But we have to face the other side of it, too. We have to face the other possibility, that our treatment will not be successful. Now, the important thing to realize in that situation is that if our treatment isn't successful, it's not as though it will fail next week or next month. It will fail a year or 2 down the line.
Well, doctor, I love the way you doctors talk. You're saying the treatment might fail in a year or a year and a half? I mean, are you basically saying to me, you've got advanced breast cancer, Kathleen, and you're probably going to die? Is that really what you're saying, if you divest it of all of the euphemisms that you guys like to use?
My guess is that if this cancer proves to be nowhere beyond the lymph nodes, there's a very good chance that not only will you not die in this very short period of time you're probably worried about, but that you will survive without any significant problems for some period of years. Those are the things we have to focus on.
Karen Stanley, appraise Dr. Newland's discussion with Kathleen.
I see a woman who is scared silly with good reason, and a very kind physician who is trying, in as much as it's possible, to say hard things in a kind way.
Are doctors very good at this?
No, it's very painful to give hard news. I think it is. And sometimes in our efforts to remove ourselves from the painful situation, we blurt it out and then leave the room. The physician could have come in and said, you have metastatic breast cancer, there's not much I can do, I'll send the oncologist in and be gone.
Will Galen, why would doctors not be all Charlton Hestons at this?
The typical surgeon is not necessarily trained, but also not by inclination or temperament, the kind of guy who's going to like to be cuddly up and get into emotions. Most guys aren't, most men aren't. A typical surgeon is still a man today, and as I say, of all the physicians, he does less of it. He's really seeing bodies for the most part. He's in and out quick. Big bucks are at stake here. You've got a brain surgeon or a breast surgeon, and he goes in, he does his thing, and he's superb at it. And I don't know, and with the economy of medicine going the way it is, you really want an HMO is going to spend time, spend money for his time there, and even if you did, so everything is in concert, in a sense, for this to be a bad scene, let alone the fact it's a failure. It is failure, even though it isn't. Doctors don't like to see failures any more than anybody else does.
Dr. Fagan, how do you react?
It's painful. Physicians who do it poorly are physicians who have not had to come to grip with their own mortality, who are not comfortable with death and dying, and they often will extricate themselves. They'll give a diagnosis and leave the room quickly. The important thing here is that most patients, after you say the word cancer, don't hear anything else, and to go on and talk about the other information which he gave, which was very good information, is gone. She won't remember that tomorrow.
Well, let me tell you something you haven't taken perhaps into consideration. I don't know this woman. We are about to begin a long journey together. The journey may end with her death. I know nothing about her spiritual values. I know very little about her family. Even if she has a primary physician, the way we work in America is that from here on in, I am responsible for this woman. So I have to create for her two things, optimism and the sense, which I think I didn't do very well, that I will be with her throughout the process.
And you think it's appropriate that the primary care physician has sort of handed her off to you and you can deliver this news, even though you yourself say you don't know her?
I don't know what's appropriate. This whole thing is so irrational. Cancer is irrational. The setting in which we treat it is irrational. It was pointed out a moment ago, the moment that word appears in the vocabulary of the two people talking, bingo, the rest of the conversation is shut off. And it's been my experience that it's sometimes shut off just before that word. Remember what we're talking about. We are talking about the prime instinct of living human things, to stay alive. And someone has just said, you may not stay alive, and everything shuts off.
Right. Let me move the clock a bit. Kathleen has a radical mastectomy, radiation, chemotherapy. She comes out of it all beautifully. It's miraculous. For about a year. And then a reversal sets in. And if anything, she's worse, and she's going through chemotherapy again. Dr. Payne, you do this, but it's not working. You reach the point where you are confident, bad word, I suppose, it's not worth it. It's just not worth it. Tell her.
Kathleen, you've had several courses of chemotherapy. You are really not much better. You've been getting sick. You're not feeling well. We have objective evidence that the cancer really hasn't responded. I would recommend that you not have any further chemotherapy. And that at this point, we really emphasize treating pain and other symptoms.
Now, by nature, you are a fighter. Indeed, the whole family wears buttons, and the buttons say failure is not an option. Now, Art Kaplan is your brother. You two have a conversation with Dr. Payne.
You tell him, sis.
Well, Dr. Payne, this conversation reminds me of the conversation I had with Dr. Newland when I first came out of surgery. Emphasizing other aspects, do you basically mean you're giving up on me?
No, at this point, the best possible treatment is not to persist with more chemotherapy, but really to persist in treating your symptoms.
Well, let me tell you what I want to persist in. I have a 14-year-old daughter. I want to make sure I'm at her high school graduation. You tell me how I can do that.
Unfortunately, I'm not certain that I can guarantee that. I would very much like to, but your cancer hasn't really responded to the treatments that we've provided. There are other possible experimental treatments that could be tried.
That's what we want to hear about, Doc.
Yeah.
What are you talking about? I read actually, you know, in the supermarket recently about a experimental treatment, something having to do with lasers, I think it was.
The issue here is whether it is in your best interest to pursue these experimental treatments, which are experimental because we don't know if they work.
Of course it's in her best interest if that's all
Because
she's
the
got.
treatments may make you sicker without really treating your cancer and
Doc,
the risk.
I just have to tell you something about my sister. For as long as we've been a family, she has been a fighter. She is not a person to give up. We want to take this any place, anywhere.
Wait a minute. But what I think he's trying to tell me is I can be a real mother to my kids for a certain period of time, or I can be an invalid mother to my children for a longer
Sis, don't
period
even
of
talk
time.
that way.
If I take,
Don't even
that's
talk
what he,
that
That's what
way.
he's saying. Wait. Whose cancer is this, anyhow? This is what the doctor is saying to me. And I've got to make a decision whether I want to really be there for
You
them
know what
or
Mom
be
and
there
Pop
in a
said, though.
haze.
We fight. We're a family of fighters.
And will continue to fight. And we will continue to fight to give you the best possible life you can have.
Doctor, is it her decision or your decision?
It is her decision, hopefully with me informing her of her options. And
Deep
alternatives.
down inside, are you giving up on her?
No.
You sure?
In fact,
She keeps asking you that.
No, I'm trying to...
Sounds that way to me.
No,
too.
I'm trying to make have a discussion to inform you that we have no effective treatments for your disease.
How does somebody in Dr. Payne's position know what is best to say?
I think Dick was starting to do it very nicely, but you really have to stop giving information and listen to where the patient's at, where this illness fits in their life at the present time. I have to say, sometimes the wish to make people better and save their lives is so strong that we continue to persist with really futile life-prolonging measures way beyond where any reasonable person would
But
say
I'll
we
ask
go.
you what I asked our Kathleen. Isn't that her decision?
It absolutely is.
Isn't it convenient for you to turn off and walk away?
No, it's convenient, no, because it hurts to do that.
It's easier to offer another choice or another treatment to tell the patient that there's nothing new or reasonable to offer. I mean, there's always another treatment that can be offered, and the courage or the guts come when you say, there really isn't anything more to offer. And most physicians are too afraid to do that.
There are certain things that don't want to be heard. Kathleen didn't want to hear from Dr. Payne that it was at the end of the line for her, this treatment. Now, I have to admit that he didn't want to say what really was going on. When he said, I didn't give up on Kathleen, I don't know what he's talking about. He gave up on his treatment. He may have meant, I didn't give up on her as a person. But even if he'd have said it perfectly, and even if all of us were just perfect at saying things, you're talking about death. You're talking about the ugly relative at the wedding. No one wants him there.
Doctor, does there come a point where you've got to say to Kathleen, your managed care simply won't fund this any longer?
I hope not. I am hopefully continuing to advocate for your best possible care and fighting the hassles of dealing with the managed care organizations to do that.
Well, doctor, the thing is, I really want to die in the hospital. I want to insulate my family as much as possible, and I want to make sure that my managed care organization will let me do that.
Unfortunately, that may not be your ultimate decision, although I will try to support that.
Despite what he may want to offer her, the managed care organization will put limits. They will ask, is there another environment, a less expensive environment, where this care can be provided?
Well, let's assume that the managed care organization actually has not withdrawn support. But, Doctor, it has a pilot program that it's testing, and our Kathleen may fit. It's very simple. If a patient in Kathleen's condition is willing to forego all aggressive treatment, which at this point looks fairly hopeless, the managed care organization will make a sizable lump sum payment to the patient. And you know she is worried about the kids and their college education. You tell her about this?
I probably tell her because I'd like to think I'm honest, but I'm very uncomfortable telling her. Because we've now introduced, in a very a real way, a whole financial issue, which I hope will cloud my and your best medical decision.
You think there's something ethically wrong with this offer?
Well, ethically wrong might be a somewhat weak description. Encouraging them to swap a couple final days of life, maybe for the big reward. It's all right. Maybe in Atlantic City, doesn't seem to be so hot as an offer for a coerced dying person at Centerville. No patient should be asked by anybody to swap the final days of their life to win a monetary prize by the company that's supposed to be, with its folded hands, big rocks, Snoopy, looking out for her interest.
Don't you think this is America?
It's much harder than that. It's much more difficult. We do this all the time as a country. This is exactly the deal we put in front of people who face impoverishment with serious chronic illness in Medicare and Medicaid. You can choose a course of care which will see to it that you do not live a long time and thereby leave your spouse with something to live on. Or you can spend down to impoverishment and eke out the last, and we'll all support that. We'll pay all the bills. But incidentally, you will be left with the spouse having the house, the car, and $3,000. And, you know, to think that that is a different deal than she's being proposed is somehow to sanitize our public behavior.
Mm-hmm. You hear about this. You're the patient. What's your reaction?
I want the money. I want the money. I have 2 children.
There's a genetic problem in this family.
I have 2 children who have to go to college someday. I have already realized, slowly but surely, that I am not only not going to be there when they go to college, I am not going to be there when they go to high school. I am tired of any kind of treatment, much less aggressive treatment.
Don't give up.
There are 2 words I have gotten so tired of hearing throughout this entire process from my doctors, from my rabbi, from my minister, from my friends, and now from you. I understand. None of you understand. None of you understand what it's like to be me now, and don't say it. And you don't understand, and I need this money for my kids, and I'm going to take this money for my kids. I'm at the end of my rope.
Nancy? Problem here or not?
Patients have the right to die according to the rules that they set for themselves. It's so hard for our system to stop making moral judgments about the behaviors of patients when we're dying. We're supposed to die without losing our ability to meet everyone else's expectations. But the patient is facing her own death, and she wants to do it in a way that comports with her values, and her values as a mom are that she worries about her children first. So for the most exalted of reasons, which is we don't like managed care companies and what they're doing, and they're bad, they're evil, we'll take away her ability to choose. One more time when she will be assaulted by our values, not permitted to act according to her own.
Finally, Kathleen and the family acknowledge that she's going to die, and the family says you've got to alleviate pain and suffering at this point. Now, one night, when the basic doctors and the basic nurses are off, Kathleen's pain increases and increases and increases. And the night nurse says, we have to give her more dosage. The only one else present is a resident. He's just out of medical school. He's never seen Kathleen before. He looks at the chart and is horrified at the amount of the dosage that's been given, let alone the prospect of giving more. I'm going to ask you to role play, Dr. Payne. You're that resident. The experienced night nurse is saying, up that dosage.
Every textbook I read never told me to give a dose this high, and she may be dying, but I don't want to kill her tonight. So...
Why not?
I don't know her. I'm the covering resident, but I don't know her, and you're asking me to write the order.
I absolutely am, and I'm going to keep asking you until we can get this solved. What I'm asking you is nothing. This is almost a spit in the ocean, but we have, listen up here. We have an ethical obligation to relieve, listen, please look at me. I've been here.
Yes, ma'am.
We have an ethical obligation to relieve her pain. If you feel that you can't help me with this, then you need to direct me to someone who can, because we have to get her this medication. We cannot, I'm telling you, we cannot let her lay here and suffer like this. Would you want this for yourself?
No, I wouldn't, but I don't know her, and I don't want to be the person to cause her death.
What are you worried about? That you'll be sued if you give her the dose and she dies?
Yes.
So you're gutless.
That sums it up.
That's one way to put it. Yeah.
Are you worried about your license?
Yes, I'm very worried about my license, because I think that there's this medical board and there are these bureaucrats in my state capital who are looking at how I prescribe these medications. And if I'm reckless in my prescription of these medications, so they say, I might lose my license.
What do you think, Joanne? Are these apprehensions real?
Well, he's terribly misinformed, poorly educated. He luckily has run up against a nurse who's got some spine and some knowledge, and probably she's going to see to it that someone up the chain of command overrules him if he doesn't learn a lot real quick. If he can stand there next to, or sit next to a patient who is writhing in pain and moaning and walk out and do nothing, he deserves to lose his license, among other things. This ought to count the same as an obstetric emergency. It ought to count the same as a patient bleeding out in the OR. I mean, this is a terrible emergency. It ought to be treated as an emergency, and the institution has to be supportive of that.
But if she dies on his watch, he's going to have to explain this. It's the nightmare of a resident to end up with the professors scrutinizing what you did in the middle of the night.
Is he simply unique? The world's most insensitive?
All physicians, regardless of their experience, are afraid of making a mistake. And the problem is with where he is in his training, he has more to fear
While this debate is going on, Kathleen's been in pain, but suddenly her heart stops. And our resident does exactly what he has been trained to do. He goes directly to her bed and brings her back from death.
Yes, sir.
You have saved her life. You did not notice that on her chart at the nurse's station, it said, do not resuscitate.
I think the only reason he got her resuscitated was that I was up in the bathroom or someplace. If she has no family and no one to protect her and no one to squeak the wheel for her, then she's in trouble.
But
vis-a-vis
listen
him.
to what we've all just done. We've said, unless there's a courageous nurse, unless you've got a brother there, unless you've got someone to advocate for you in the system, you're going to have a lousy, painful death.
The fear isn't that of having a wrong-headed resuscitation at the end. It's all the stuff that went before. The risk of not having elegant pain management, or not being cared for with elegance and grace, or not having a meaningful experience. I mean, who's talked to her about videotaping what she wants to say to her daughter at graduation? Who's talked to her about where she wants to be buried? What she wants to be said at the funeral? How she wants the funeral to run? How she wants her children to remember her? Does she have a chance to write letters? Those things are what we utterly are blind about.
This is what happens. She's been resuscitated, perhaps improperly. Unfortunately, in the 2 or 3 hours before her death, she was in terrible pain. Now, brother, how do you react to that? Your sister is now dead.
I gotta sit down. I knew this was gonna come, but I gotta think about this for a minute. And having thought about it for a minute, I'm gonna get these creeps. I've never trusted them from day one. I don't believe that they did everything they could have for my sister.
Anna, if you could speak to us from whatever cloud you are currently inhabiting about the way you died, what would you say?
Oh, that I don't know from beginning to end whether it could have been any better. I don't know whether anything that any of you said to me could have made any difference, really. Once I heard those first words and knew intuitively what I knew by the looks on your faces and the euphemisms you used, and that I don't know whether it's possible to be dignified when your body is breaking down on you, and I don't know whether it's possible to manage the pain in the way you want. Maybe we fool ourselves that there, somewhere out there in the ether, there's a way to do it to make it right, when in fact there isn't one.
Dr. Byock, look at this. She dies alone, in excruciating pain, getting treatment she doesn't want and doesn't need. Are Americans dying that way?
Unfortunately, I think they are. Too many of them are. It's an absolute national tragedy. It's a national crisis. It's a national shame. We should heed this as a call to action, to make it different.
You know, so much of this discussion was Kathleen seeking technology and medicine as a way of easing this process. Have we lost spirituality, Reverend?
In the process, we have lost it. It may give a lot of answers that will prevent all this pain and extended suffering that goes along the family. I think that in this particular case, the dynamics of spirituality and healing are the miracle that we lost in the conversation. It has to deal with her own sense of living. The way you live at the end will say something about the way you die.
Rabbi?
We are lacking the spirituality which teaches us not pain control, but suffering control.
Amen.
I think we have gone a long way to pain control. We haven't budged on suffering control. Part of the suffering control has been done by hospice, the only institution that has done it. And in hospice, we can get people who talk about oral histories, about giving back power, about learning the meaning of life, about connecting with God. you can recognize that your pain is part of a larger picture, that there is a meaning to suffering, then dying would not be quite the horrific moment that it is.
Joanne, you were at Centerville General that night, and you have vowed that this really shouldn't happen, that your patients should plan all of these issues regarding death. Now, you've got a new patient today. His name is Alan Russo. Alan Russo and his wife were frequently seen at Browser's bookstore. They were always in the travel section. Alan's 65 and she's 61. They've just come back from their second honeymoon. They went to the Galapagos and they rode giant turtles and they're fit as a fiddle. He's in your office and you have spread all sorts of pamphlets out about advanced directives. What do you say to Alan?
Well, what I really want to know from Alan is whether I am correct in my assumption that if he were ever too sick to speak for himself, that I should rely on his wife. And then I want him to give me a little bit of advice at that point about what kinds of things he thinks about as he faces growing old. Let him get a few things on the table. And then just say, you know, as you get older, I'm going to keep bringing this up each time we see one another.
You're Alan Russo, and you're sitting there, and here's this pamphlet on advanced directives. You read it?
Got any travel brochures?
Why don't you read it?
Got nothing to do with me. I'm interested in living my life. I'm interested in talking about death. I'm vigorous. I like to travel. Got things to do. Give me it when I need it.
Well, there's nothing else to read there. So, you start, what's in there?
All right, I'll browse it. But I'm not worried. My wife is here. My relatives are here. They'll take care of it.
Claudia, what do you do with it?
We all die at some point in our lives, and we should have a say about it when we're well and it's not a threat and that we can have some thoughts about how we would like that to happen.
Have you ever looked at that thing?
Yes.
I mean, it's filled with all sorts of stuff. CPR, ventilators, hydration, nutrition, terminal. I mean,
the easiest thing
must have
to
been
do,
written by a lawyer.
For sure. For sure, they're in charge.
You're very persuasive. You wear them out. Over time, you wear them out. And what he tells you is, look, I never want to get on those damn machines with all those tubes. And eventually, you get them to sign an advance directive. Now, for 6 years, the Russos continue like two kids, traveling the world, having wonderful time. Then one autumn morning, when Alan is out back chopping wood, after which he puts on his rollerblades, and off he goes, he has a terrible stroke. And they bring him into Centerville General. They immediately put him on life support, and indeed, looking at his face, he does this with a very grateful expression. What good's the advance directive?
Well, I mean, anyone who's short of breath or can't breathe is relieved when they finally get oxygen. Not being able to breathe is the most agonizing experience that someone
And
can
if
have.
at the moment of putting the device in, he said, help, help.
There are all kinds of ways to give help. You could medicate him in a way that his not being able to breathe would not be as uncomfortable.
Help, help, not ready. He told his wife and at least one of his children, I never want to be on those machines. That's what he told his wife.
100% of people say, oh, no, I didn't mean that. I only meant if I was going to live on it for all the rest of my days, if I was going to be in a terrible condition, if I was dying anyway, Say, oh, so now we're more clear. You don't want to have this just dragged out on
So this
machinery.
is very Talmudic, huh? You have to
Ah,
look at the
very
footnotes.
much so. Very much so.
And the interpretations?
Yep.
What does a lawyer say about these documents?
Unfortunately, many of the documents that people sign don't mean what they think they mean, and they don't reflect what patient wants. The patient means, if I'm not able to recognize family and loved ones and not able to make decisions and not able to get better, but unfortunately documents come into hospitals at all times of the day and most often the night that have these absolute statements and present tremendous problems for physicians and even more so for hospital administrators. And a confused hospital administrator is a dangerous person.
He is still functioning. He can communicate. And he appoints his daughter, Antonia, as his medical surrogate. That's you. As of this morning, he's lost the ability to communicate. He's totally unresponsive. You think Dad really would not want to be on this machine, that this is what he meant. Clearly, when he said 6 years ago, I don't want to be on machines. You are another daughter, Kathy. You are 4 months pregnant. Your position is that when you walk into his hospital room, he seems to light up a little bit. And it's your conviction that Dad definitely would want to see his first grandchild. Will, you're a brother. You're not sure whether he's there or not. Your feeling is it isn't ethical to withdraw him from the machine. What do you say, Antonia? You have a document. The document makes you the surrogate. It is legal, binding, you've got the authority. What do you want to do?
Guys, if he said to me once, he said to me 100 times, I don't want to be on those machines. I look at him on those machines. I know that this is what he was fearing all those years. Doctor, I want the respirator off. That's all there is to it.
Now, wait a minute. I go in there and I talk to Daddy and I put his hand on my belly and I see him. I see his face change. I know he's in there. You're killing him if you do that. He'll get better.
Wait, who's the person to decide, Daddy or you?
He's my dad, too.
Yeah, but he made this decision for himself. He designated me. He told me so many times that he didn't want to be on the machines. Who are we to take the choice away from him when he can't speak at this moment?
I've heard you girls squabble all your lives. And it's always about Daddy did this and Daddy did this and who's Daddy's favorite and what. Maybe Daddy didn't want to be on the machine, but he is now. Don't we have some religious conviction, some sense that while he's there, to not put him on may have been correct, but should we really pull the plug? Can you live with that? Isn't that murder? Isn't that something that in a sense offends everything that Daddy taught us? He taught us to go to church, to believe in God. This was God's will, I guess, to have him on the... I just don't understand you girls. You really want to pull that plug?
This machine has nothing to do with God's will. This is the doctor's will. When we take him off the machine, then we'll find out what God's will is.
Well, God gave the doctors the sense to invent the machines to put him on there. I know he's in there.
Wait,
and I
wait.
believe that Daddy's getting better.
Wait, I am still your mother. I am still your mother. And you may have the document Daddy signed because Daddy didn't want to burden me with that. I just don't know. I think we need a little help. Connie, is he there?
Well, I think the question to be asked is this how he's always going to be? Yes, there might be a little cognition there, but if he's going to be like this, unconscious for months and months and forever, is this how he would want to be? And would he want to be kept alive in this condition?
Reverend, you've always talked to the family about spirituality. Does he still have it?
While he's breathing?
Yes.
He still have it.
What's a mother to do, Rabbi?
I think morally we are not permitted to pull the plug. The man has life. The man may come out of his coma, as so many do. And who are we to act God? I think you can withhold it.
Are we back in the miracle business?
No, not a miracle business. But people do come out of comas.
What do you want to do?
Somebody asked me if my father's breathing. My father isn't breathing. A machine is breathing. A machine is inflating and deflating his lungs. You could do this to a person probably an hour or two after they were dead. This is exactly what he feared, living in this condition. I want this machine stopped. He's being tortured.
You know, you've convinced me. I think you're right. I don't think it's God that's keeping him alive. I think it's modern technology, the machinery. You're right.
His heart is beating. He is still there. He responds to me. Maybe he didn't like you. Maybe that's why he doesn't respond to you. He responds to me. He knows I need him. And I need him, and I want him here.
Dr.
And you're
Biot,
killing him.
Let's assume that Tony, despite dissent from within the family, she has the legal authority, and she says, here is my surrogacy. I want you to unplug my father right now.
My answer is, I will support your surrogacy and do what you ask for, but not this moment.
Here's the piece of paper. Unplug him.
I'm not a mechanic here. I'm a physician, and my focus is not only on the heart and the lungs and the dials on these machines. It's in acknowledging the human experience that's taking place here. This is a critical experience for your family, probably the most important thing that's ever happened in your family since your birth and your brother and sister's birth. I have to have a sense that all people's values and their stake in this, because they have a stake in this too, are being heard here.
Let's suppose a doctor agrees to do it. You think that's a decision that should come up to the ethics committee or hospital council?
No, I don't think this should go to the ethics committee. I think that the doctor should respond to this spokesperson for the patient and should set a plan. Maybe not this moment, but in 48 hours, I will make one more attempt to talk with your family because I don't want them to suffer, but then I will do it because, in fact, it's what your father wanted, and you're his representative, and yes, I will plan to do that. Give me 48 hours to work it out.
Well, fortunately, in the midst of the 48 hours, Kathy has an unbelievably vivid dream. And Dad comes to her in the dream and says, I'd like to be released from my earthly body. That instantly brings uniformity, and the machinery is withdrawn. Let's now meet someone else from Browser's bookstore. It's Paul. Paul always used to be reading books on patients' rights. He has AIDS. You think he's got about 6 months to go. He says, the only way I am going to have any sort of death with dignity is with assisted suicide.
First, let me say that patients with AIDS who ask for assisted suicide are in a totally different category than any other patient that does, because it turns out that in this particular disease, there is the highest frequency of people asking for assisted suicide. They have seen people die with AIDS dementia, which means they really have no idea of who they are or where they are for weeks or months before they die. They have seen people die blind because of the so-called retinitis that affects the inner aspect of the eye. They have seen people die with infections and sores all over their bodies. They have seen people wasted into 70-pound wraiths. That's not the kind of thing that you can see without, when the diagnosis comes, thinking seriously of suicide.
Ira, you've known me for some time. This is what I saw with my friend. Now, what can you offer me? as an alternative?
I can offer you the best that I have in my mind and my heart, and a team of people who care about you not just as a person with the disease, but as a human being.
Connie?
My sense, Paul, is that what you and some of the other people in your community have experienced is death without the kind of support that you need, and that's the thing that we can offer you, is people to be with you so that you're not alone. And I think pain is a narrow part of the experience, and suffering, it's physical, it's emotional, it's spiritual. It can even be financial. And hospice teams are prepared to look at all parts of the suffering, not just the physical.
You know, I'm very interested, very impressed by. So, I'm not going to pursue assisted suicide at this point, but doctor, I want to hold that back as an option. And I'd like your commitment that if the time comes when that option is the one I choose, you'll help me.
I'll do everything in my power to make certain that you are not in pain and not treated in an undignified fashion. The one thing that I won't do is act with the intention of killing you. It's just not part of my job description, Paul. It's not part of
Doctor,
what I do.
It's not me anymore. When it reaches that point, it's not me.
You're not who you are. You're absolutely right. But you know what? There are relationships there that still can grow in the midst of this process.
But isn't it my choice? Isn't it my choice? Connie, would you help me?
What I would help Paul do is find someone who is comfortable helping Paul. In all due respect to this doctor who can't, there are some physicians who can, and I think it might be a great mental comfort to Paul to know that there would be somebody out there who would assist him if that's what he finally decides to do.
Karen, would you help?
For a patient to ask that question of one of us, I think requires a phenomenal amount of courage. But walk with me through the situation for a minute, if you will. A friend and a colleague has leukemia. I'm with her when the disease recurs. She says to me, "I'm going to die, aren't I?" And I say, "Yes, I think so." Ultimately, she chooses no further treatment because it's relatively futile anyway as this particular kind of leukemia goes. An emergency arises. A significant amount of pain suddenly. And one of the things that I have promised her is that I will never abandon her. It's very clear. This is close to the end of her life. And I'm sitting on the bed holding her. And she says very clearly, "Would you please give me a shot so I can just go to sleep? I don't have enough courage to do this anymore." At that time, I felt that I was the one who didn't have any courage. There I was in the face of this, what seemed at the time to be a very reasonable request, and I felt cowardly and ashamed. And you know, if I were in that position, I mean, for myself, I would want a trusted friend there that I could ask to help me, and they would just do it.
And that's the real dilemma, that on the one hand, we want to protect the physician's role so that he not be a death dealer. On the other hand, for my wife, I would do it. For my daughter, I would do it. She had a friend. All of us sitting at this table, by dint of our profession or our sociology, have at least some hope that somehow or other someone will do it, whether they will just give us the information or actually do the injection. That's the true doctor's dilemma or medical dilemma of dying.
You know your wife well enough. You know your sister well enough. You have the relationships and the bonds and the understanding. As an institutional policy, as a law, as a practice for the profession, I don't think the system is up to it. If I dare call it a system, this mishmash that we have with some people offered hospice and Paul being led down the road with options, and other people homeless, uninsured, dying in the street, IV drug abusers. Where's the conversation there?
But we put it under this entire rubric called assisted suicide. There's a qualitative difference between firing something into someone's IV line that's going to stop their heart in a matter of minutes and writing someone like Paul a prescription. Just writing them a prescription which they can fill if they want to. Over and over again, I hear that people find solace not in taking the pills from that prescription, but in owning that prescription. Because this discussion about assisted suicide is not about wanting to die. Again, it's about wanting a sense of control, a sense that somehow you get to make the decision and not